after finishing heart failure, we're going to go a bit into cardiac, the fetal cardiac anomalies. Just like as small ideas about each one of them. And then خلاص يعني, inshallah, this session will be a very quick one. We're gonna يعني, mostly wrap a lot of the physiology lectures you guys took this semester. Of course, if you have any questions, يعني, you know my number, كلكم شفتوا رقمي بالimportant. You can ask me whenever you guys have any questions. Inshallah, I'll be ready to answer any of your questions. طيب, let's start. Frank Starling curve. Okay, قبل ما ندخل على next slide. Does anyone not understand what this is? ارفع ايديكم. Because I need to know اللي بيعرف من اللي ما بيعرف عشان I know how to explain it. طيب, all of you know it, صح؟ طيب. أنا حجي. Okay. هلا I'm gonna explain it in a bit. هلا, does anyone know what this is? You took it last year. For?
The muscle.
What muscle? Skeletal muscle. طيب. The thing you took last year, just replica of it is this, the Starling curve. Starling curve is simply the tension force curve that you took back in the MSK unit. Hello, what does this mean? طيب, for the MSK, let's talk about something you took and then we relate it to what it means in the cardiac chapter. For the skeletal muscles, the actin and myosin, they have to overlap at a certain point, which is seen at this length, that gives you the highest amount of tension. But this is a
Sustained tension.
بالضبط, يعني it gives you the strongest force at a certain point of overlap. حلو؟ هلا, كونه the heart is also a muscle, they have the same logic, right? As the myosin and actin overlap, there's a certain point where it gives you the highest force as well. طيب? هلا, of course, the difference between them, the first difference that we have to understand is the muscles, there's a point where the actin and myosin start overlapping, like it becomes more of يعني less of an overlap and more of a يعني بيبطلوا انه they're above each other, بيصيروا يعني exactly, and they will cross each other to the point that it doesn't help in the tension. That's why you see the tension going down. The difference is the heart muscle doesn't work in the same way. The heart muscle just keeps going up and up and up. Right? It's because of a physiological phenomenon where the calcium allows the extension of the actin and the myosin. طبعا this detail I didn't add because it's too much for you guys. But what you need to know is exactly as this is a length tension curve in a muscle, يعني كل ما مطيت المسل, it gives me a bigger tension to a point where it stops giving me that amount of tension and starts going down. The heart muscle has the same exact idea. بس هلا, the reason we use length as the x-axis in our graph and tension as the y-axis is because this is how we can measure muscles. We can measure how long they are and how much force they produce. طيب? How can we measure the heart in the same fashion? Because again, we can measure how يعني tall a heart's muscle is, but في الآخر we can never bring a tape and measure someone's heart because it's inside. So what other measurement can we use to measure the length لحال يعني? In diastolic volume, or also known as?
No, not stroke volume.
Preload. Also known as preload. طيب? اللي هي in diastolic volume or also known as preload. Imagine the heart is exactly like a شو بسموها بالانجليزي؟ Elastic band, exactly. طيب, the heart is like an elastic band. The more you fill it, the more the elastic band goes down and down and down until it contracts and shoots the fluid inside it. نفس الطريقة بالضبط. The way the lengthening happens in a heart muscle is by filling it up. It يعني extends till it gets, again, similarly to the muscle, it gets to a point where its tension is the highest. But as we said, tension in cardiac muscle does not go down, at least in a normal physiological condition. Right? We're going to talk about the how it changes later on, مثلا in heart failure. But as in normal, the more you extend the heart muscles, the higher the tension it gives you. But كمان, how can we measure tension in a heart muscle? Using either cardiac output or stroke volume. What do I mean by this? Again, in muscle, how do we measure whether a muscle is strong or not? بنشوف إن الشخص can he hold this amount of force or this amount of kilos, and these kilos we can then convert them into forces. This is يعني how we can calculate the force or the tension produced by a muscle, skeletal muscle. In a heart muscle, ما نقدر نحمل الهارت weights for it to see if it's strong ولا لا. The way we know if a myocyte is strong or not is through the calculation of the cardiac output, or in other words, the stroke volume. فزي ما هون exactly, زي ما هون we have tension on the y-axis and in the x-axis length, right? in the heart muscle, the length is measured as in preload, and the y-axis is measured as in cardiac output. It's a resemblance يعني type of thing, إنه زي ما عندنا strength and tension in a skeletal muscle, cardiac output is how we measure whether a heart is strong enough or not. So similarly, the same way we have length in a heart muscle, the end diastolic volume or preload is how much the heart has stretched out. طيب فهمتوا هالفكرة ولا لا؟ طيب this is an important idea. يعني the whole يعني if we're gonna summarize the whole thing is من الآخر this is يعني how strong the heart is working. طيب the same line if it goes down طيب معناته the heart is starting to weaken. And what happens to here يعني the surprising thing is okay طبعا actually this other curve is better. هلا in a normal condition it's يعني goes up, it keeps going up until it actually reaches a plateau. The plateau is actually not because the heart muscle cannot exceed its tension, it's actually because the heart's cavity does not allow to stretch even more than it's stretched. It's a closed cavity بالآخر. But while مثلا in a exercise, a person who is exercising, or for example a patient who starts taking positive inotropic drugs, what happens to the tension curve or the Starling curve for the heart goes up a bit because اللي بيصير and what's the idea of it going up? It's telling you that for a little amount of blood it is pumping even more. يعني for a little amount of stretch the heart is producing more force. And again, how do you measure stretching of the heart? How do you measure it? الEDB or preload. أحسن تحكي preload. Preload is usually what's يعني it's set or given. طيب preload. And how do you measure the force of a heart? يعني stroke volume بالضبط. يعني how much it has pushed out of the body. طيب ممتاز. فagain positive inotropy and negative inotropy is exactly what we use in this graph. إنه مثلا if we're gonna say positive inotropy معناته it simply means for a lesser amount of blood the heart pumps even more. So what happens to our curve? It goes up. Look at it here, okay? بالضبط. A normal heart is like this. حلو? Positive inotropy allows it to go up. فمعناته for a lesser amount of end diastolic volume or preload, the heart pushes out even more blood. Right? So the cardiac output and the stroke volume increases. Okay? هلا اوكي ممتاز. احنا حكينا so much يعني explanation بس خلاصة الموضوع ايش؟ هلا when we get to the venous return graph is what are we من الآخر what are we showing here بالheart? What are we trying to show here in the heart? مو بس contractility, we're trying to show its function صح ولا لا؟ The function of the heart is what? Simple words. To pump blood صح؟ I want to see how good it's pumping the blood by measuring how much it stretches and how much this stretch gives the heart a force to push the blood outside the body. فهون احنا we looked at what function of the heart?
Cardiac function.
مش كان what specific word? Non-contractility. صح كلامكم صح. Not output. What function is this of the heart? What type of function is this? Systolic. But this is the systolic function. هلا because we're gonna get into another topic because this is the easier part of the graphs. The harder one is what we're gonna get to in a bit. طيب before we go into the little bit more يعني شو اسمه confusing part of the heart's functions, MSP, not MAP, not mean arterial pressure. MSP is simply the mean systemic pressure. يعني من الآخر I look at the pressure within a patient's veins or arteries when they're dead. In other words, I'm seeing if there's pressure in the arteries or the veins when a patient is dead. How much do you think this pressure would be? 8 to 10. Who says less or more? And how much the pressure of the arteries or veins of a patient who is dead, how much would you give it?
0.
Who says 0?
طيب
الحمد لله you guys are in medicine because pressure means شو الpressure? What's pressure?
Force divided by
It's not force, not just force. حتى يعني for example blood inside a pipe gives you pressure. Blood inside an artery أصلا produces pressure as it is. الحمد لله you guys are in medicine. Actually I'm just joking by the way. حتى I used to think it was 0. It's not your mistake. But no, yeah. There is pressure within, even if the heart is not contracting, the fact that there is blood within an artery or a vein, that on its own produces pressure. The contraction of the heart just increases that pressure for more. Why would you want to increase the pressure? عشان you want the blood to move. بس هي الفكرة. So what is MSP again? It's the pressure within the vessels in a dead patient. Or in other words, the pressure of the vessels if the heart stops stops contracting. بس يعني هي الفكره انه كم البريشر جوا الفيسلز when the heart stops contracting. هلا واحد بيسالني طب Rashid, what's this? We never talked this. I don't understand why you're talking about this because this will relate to something else we're going to talk about in a bit. طيب what they found out اصلا طيب later on is the MSP is actually very similar to the pressure of the veins. Why is this a problem to some of you guys? No, the pressure of the veins is the same as the MSP. The MSP حكينا is the pressure of the vessels in a dead patient. The veins have the same pressure. فمعناته يعني systemically speaking شو عم يصير بالveins؟ مش no pressure.
Carrying all the blood.
They're low pressure. Carrying all the blood is صح ها؟
Are you talking about the compliance?
MSP again. كيف احنا how did we calculate MSP? What was the condition?
No heart rate.
Huh?
No heart pumping.
Thank you. So when I tell you the MSP's pressure is actually this nearly equal to the veins pressure. معناته what's
Heart
the
failure. Zero stroke volume.
No. You said it هلا قبل شوي.
Heart failure, no pumping.
ما veins are always in heart failure. دائما في heart failure بالveins.
Blood
What?
schooling.
What
are you asking?
In MSP, طيب the pressure is equal to the pressure in the veins. In MSP, طيب the heart is not contracting. How does it make sense that the veins have the same pressure in a live patient? يعني نفس ال MSP.
That means that all the pressure that the heart
Because
is
veins
making
have
is
high
lost
compliance?
in the-
Thank you, exactly. This is exactly what I want to hear. All the contraction that happens on the left side or in the systemic area ends where?
in the
Arteries. That's exactly what I want to hear. In other words, speaking in other terms, the veins are a dead area of the, يعني a dead place in the body.
Unstressed volume.
Huh?
Unstressed volume.
It's known as unstressed volume. بس الفكرة وين يعني ليش اسمه unstressed volume? Why is it called unstressed
Doesn't
volume?
affect pressure.
But it's not that. The contraction of the heart does not affect the veins. طيب؟ هلا I'll explain to you why this is important. Because since أيام زمان actually I will actually ask it in a very simple way. طبعا anyone who knows the answer because I've asked this to some people don't answer. I want to see how people will answer it. How does the blood go back to the heart?
The difference between the pressure in the veins and
How does it do that?
Valves, muscles.
Okay, that's good. Right. What I don't want to hear, the reason I'm talking about this is I don't want to hear, the left ventricle contracts, pushing the blood all the way through the arteries into the capillaries, back from the vein into the right atrium. وطبعا this is a common knowledge between people that they think this is the cause. But if you think about it, is the MSP is the pressure of the vessels كلها. When a heart does not pump, and it's also equal to the veins pressure, معناته clearly the veins pressure is not affected by the contraction of the heart. معناتها clearly this knowledge you have to remove it off your head because it would only make sense if the veins pressure was higher. Because again, شو حكينا ال MSP was what? Is the pressure of the vessels if there was no contraction in the heart. صح؟ وقلنا كمان إن the veins have the exact same pressure. فclearly the veins are not being affected by the contraction. يعني هو الveins قاعد ولا كأنه there's a heart contracting. Logically now the next question you should ask is طب how is the blood going back to the heart? This is exactly where the venous return curve comes into place. What they found out, by the way guys, the reason this confusion is there in cardiology, and if you go ask any foundation مثلا after they take the cardiology chapter, how does the blood go back to the heart? هيقول لك yeah, it pumps all the way from the left ventricle through the arteries, into the capillaries, into the veins, back to the heart. Clearly this is wrong, because if this made sense, the veins ما كان حيكونوا equal to the MSP pressure. Because as we said, MSP pressure and the veins pressure, طيب, both of them are equal, and the MSP pressure only came after the left ventricle stopped contracting. فمعناتها clearly the veins are not being affected كمان. طيب, ممتاز. Did anyone not understand this point? عادي raise your hand. I expect إنه people do not understand it. عشان I'm going to repeat it again and again and again. فإذا أي واحد عن جد ما فهم النقطة, just say it. Okay? خلاص ممتاز. In other words, what they found out later on, the heart's function is not one, but actually two. But it has as we said in the beginning, a systolic function and a diastolic function. What is the diastolic function? It is the function where the blood in the veins gets retrieved back by the heart. هاي الأساس الفكرة كلها. طيب من زمان فكروا إنه the heart's one function is what? Pump blood around the whole body, pump blood around the whole body, pump blood around the whole body. بعدين يوم الشغلة شو هذا؟ There is something called diastolic heart failure طلعت معاهم. صاروا يشوفوا patients where their systolic function is good. good stroke volume, ejection fraction was good, but the patient is still dying. He came with مثلا pitting edema, and the patient is not, he's not getting sufficient blood around the body, although his ejection fraction was good. The scientists back then didn't understand شو عم بيصير, why is the patient dying, although there was systolic function that was good. Turns out the heart doesn't only have a systolic function, it also has a diastolic function, which is retrieving back the blood from the veins into the heart. Right? It's not through the systole of the heart that allows the veins, that allows the blood to go back to the heart. It's actually a different system. What allows it to go back to the heart, as Mariam said, is the pressure difference that can be generated by muscles, by valves, اللي هو طيب, but the main idea is the pressure difference. هلا the pressure difference between what and what would allow the blood to go back to the heart.
Vein and right atrium.
بالضبط, the veins and the right atrium. مين لازم يكون أعلى؟ عادي, خليها عادي, فكري فيها. فهمتي ليش؟ ف clearly the veins have to be higher in pressure than the right atrium, and this is exactly what is presented in this graph. What it's as again, what is venous return? It's simply how much blood is going back to the heart. صح ولا لا? Simple terms. But it either increases or decreases. في كثير venous return, في قليل venous return. ممتاز. What the graph tells us is there is more venous return, or right atrial pressure شو بيصير في عماله؟ بينقص. For the lesser the right atrium, the more the venous return. صح ولا? You understood this point? And why is this happening? Because what moves blood? The pressure. Blood. Concentration gradient. Pressure gradient, exactly. Well, a higher pressure in the veins and a lower pressure in the right atrium means more blood flow. The lower the pressure in the right atrium, the more the return. فهمتوا الفكرة؟ This is the whole idea of the Starling curve and the whole idea of the venous return curve. إنه من الآخر الهارت has two functions. Systolic, diastolic. Simple. طيب فشو بعدين اكتشفوا بعدين؟ ما هو الحلو شو انه اكتشفوا بعدين انه كونه في systolic function, which we named it as, how did you calculate the systolic function? What was the calculation? يعني شو how did you calculate contractility?
Stroke volume.
او
Cardiac.
I want cardiac output. ما بحب stroke volume, انا ضد stroke volume, بس اوكي صح. Cardiac output. طيب cardiac output for systolic, and how did we calculate the diastolic function? And how do we know if diastolic is good or bad? Venous return. صح ولا لا؟ ممتاز. Let me give you another hypothetical idea. طيب should the cardiac output and the venous return be equal ولا لا؟ ليش لا؟ ليش ها؟ طب حلو, طب why would we need that؟ يعني بس هم قالوا yes.
ما بصير عندنا زيادة من البلد بالهاي ولا بصير عندنا نقصان.
Exactly. This is the whole idea. إنه we want the same amount of blood that comes back goes out. Same blood that comes out goes back. Sorry, comes back goes out. Exactly. ليش؟ عشان if there was, for example, more cardiac output than there was venous return, شو بصير عندنا؟ شو اسمها الحالة؟ edema, which is also known as more cardiac output than there is venous return. شو بصير عندنا؟ more cardiac output, less venous return. شو بصير في الجسم أول شيء؟ edema. وين بصير في الجسم بالedema؟ peripheral, which is also known as the disease. What type of heart failure? اسمه مش right. It's not right. Congestive heart failure because of what functional problem? Diastolic. عادي يا جماعة, عادي يعني. عادي لو بتغلط مش مهم. We're learning here. Diastolic. فهمتوا الفكرة؟ If we have lesser venous return than we have cardiac output, معناتها واضح إنه the venous return function of the heart is problematic. In other words, إذا venous return فيه مشكلة, which in other words what we're trying to say here is if the venous return is a problem in the heart, معناته the diastolic function of the heart is a problem, which we also name as diastolic heart failure. Therefore, we see edema in the periphery. صح, right-sided heart failure causes peripheral edema because the right side of the heart is mainly the part of the body that causes and that does all the venous return. هي اسمها diastolic heart failure. وإذا it's right-sided, it's right-sided. يعني إلها الاسمين. طيب؟ And vice versa. إذا مثلا venous return كان أحسن من cardiac output, what do we call that as? Systolic heart failure. طيب؟ فهلا the rule is cardiac output has to be equal to the venous return. عندنا الواي axis كان ايش هون؟ venous return. والواي axis كان هون ايش؟ cardiac output. فقالوا ليش ما ندمجهم مع بعض؟ حطوا مع بعض. Because again, يعني logically we said انه both of them have to be equal. يعني لازم الاثنيناتهم يكونوا equal. صح؟ فبضل معانا الاكس اكس اللي هو ايش؟ اللي هي preload from the systolic function and right atrium from the diastolic function. ممتاز؟ وطبعا the preload and the right atrium, the lesser the right atrium, the better the venous return, so the higher the venous return, and the more the preload, the better the systolic function, the more the cardiac output, and in the end اكتشفوا انه it intersects at a point, and what يعني this point شو أهميته؟
cardiac output.
هي مو بس الكارديك output, it's the steady state point of the heart. Here where the heart يعني works at the optimum rate. حلو؟ هلا why is this important? Simply speaking, is because إذا كان عندنا مشكلة بالsystolic function, طيب what happens? يعني the line goes down صح ولا لا؟ So what overall happened to the cardiac output? It went down صح ولا لا؟ Because it reaches here تقريبا. It went down, the cardiac output decreased. So what does the body do to compensate? It's trying to ما هو الكونتراكتيليتي ماكل الهواء يعني انه الكونتراكتيليتي ماكل الهواء شو نسوي عشان نساعد؟ Exactly, we increase the venous return. So what do we do with the مثلا the blue graph?
Shift it to the right.
To the right, يعني we shift it upwards. صح? This is exactly what happens in systolic heart failure, or as something as we know, يعني what's also known as HFrEF, يعني heart failure reduced ejection fraction. Right? The most common type of heart failure that you would see in the emergency. Right? But this is exactly what's actually happening. إنه هي the systolic function of heart failure in a reduced ejection fraction or in a systolic heart failure بيصير عندنا systolic function اللي هي اللاين الأحمر أقل. فبعدين الجسم شو بيسوي؟ بيصير يخزن fluids. By storing in fluids, what happens to the blue line? It goes up, and by going up, it betters the cardiac output. But at the same time, patient بيصير عنده fluid overload, edema in the lungs, dyspnea, edema in the foot, in the يعني periphery. He cannot walk. بيصير عنده cellulitis. بيصير عنده مصايب كثيرة. We're gonna talk about it in details, بس in a bit. Right? هلا let's look at what we need to know when it comes to the exam that you're gonna be taking, inshallah, in the end of the semester, as in what is important for you guys to know. Systolic function, طيب, we have بس هو من الآخر two scenarios where four scenarios where it will change the graph. Either positive inotropy, negative inotropy. معناته من الآخر either stronger contractility, weaker contractility, or يعني more calcium or lesser calcium, where the graph itself would go up if the inotropy is positive, or it would go down if the inotropy is negative. طيب, give me a name of a drug that causes positive inotropy. شيء أحسن منه عشان الدروكس زبالة. But the drugs is very bad.
Phosphodiesterase.
Huh?
Positive inotropy.
Yeah, positive inotropy.
Phosphodiesterase inhibitors.
I'm gonna kill you.
Wow.
What does it do?
Increases in inotropy, right?
What did PDE5 inhibitors do?
Bronchodilators.
No.
Huh? Is the camp where? Man? Where do you use us and what medic? Oh, by the way,
COPD.
COPD, asthma, and
Heart failure.
heart failure. يعني اوكي. درستوها بالفارم and heart failure. هي beta blockers are used, صح? But what does PDE? Did you guys study actually what does PDE inhibitors do?
Breaks down. Breaks down.
No, phosphodiesterase breaks down CAMP. If you inhibit it, it increases CAMP.
Okay, hello. What does that do?
By relaxation.
Huh?
Increase intracellular calcium.
And in what organ? It
Bronchodilator.
doesn't work in the heart.
All those smooth
The
muscles.
vessels.
Smooth muscles relax and
It's used in hypertension يا جماعة. PDE5 inhibitors are used in hypertension. It's not يعني if من الآخر إذا دكتور ما حكيت له something else, just study what you did. بس إنه the common knowledge PDE5 are used for either hypertensive cases or شو اسمه الثاني PDE3 inhibitors. It was used in شو مش مهم يعني I forgot بس it's not something you took. طيب positive inotropy يا جماعة. البيوتامين خدتوه ولا لا؟ البيوتامين. دوبامين. epinephrine.
It is used.
No, epinephrine. Bro, if it's used عادي, everything is used for everything. Amiodarone sorry. So no, what's its effects? Mainly it's on the vessels. It's used for hypertensive crises and
No, it
hypertension.
is for heart as well.
For heart failure, she said?
Yeah.
Heart failure, bro, it's a problem in its own. Yeah. She says beta blocker is used in heart failure. I don't understand how.
No, قبل المتعالجة. It's different.
Sorry. But I will explain it in a bit. يعني why beta blocker makes no sense to use in heart failure. طيب, again, the butamine, epinephrine, dopamine. طيب.
Here,
Yeah. Midrinone, they are phosphodiesterase inhibitors.
Yeah, you're right.
حافظة أسمع.
صح.
I'll
It was in the
check-
sketch,
I'll
he
check.
was the one doing this.
Do your research.
Yeah,
okay,
he was the one
sorry,
doing
sorry.
this.
خلاص my mistake if you took it. بس أنا صراحة I studied them and it was for hypertension causes. طيب negative inotropy, what do you use? Negative inotropy, what drugs?
We didn't take
شو what you did take?
Calcium channel blockers.
Which calcium channel inhibitors?
Non-dihydrate.
Nanda, شو اسمهم? What was their name? Which one is the more potent? What class of antiarrhythmics were they?
Class 4. 4.
Was it 2 or 4? 2 was better blockers. طيب okay good. What else can I ask on? طيب حلو. For the venous return curve, how can we increase? يعني how can we shift it to the right or left?
Increasing volume. and
Exactly.
decreasing volume.
طيب هلا هون we're gonna actually talk about the MSP again. طيب. Did you guys study about this by the way? In increased and decreased total peripheral resistance. طيب جماعة بس شوي عشان
MSP is
ننزل.
the same.
اه؟
MSP is the same.
اوكي ماشي.
Not-
Something that's important that we need to understand in increase and decrease total peripheral resistance versus in increase and decrease blood volume. طيب. In blood volume and in total peripheral resistance, طيب. What's important to know is, okay, in increase and decrease total peripheral resistance, if you see it and compare it to the positive and negative inotropic effects, it does the same thing to the systolic curve, اللي هي Starling curve. It just decreases it and increases it, as you can see here. Right? But increase or decrease, it doesn't change it. Hello? While when we increase blood volume, if you realize there's some slight difference, there is a shift. It's not just going up or down. In other words, what we're trying to say here is an increased blood volume, the x-axis عم بتغير عندنا. On and on. But in increased TPR, what happens to the venous return curve is the x-axis is the same. The idea behind this is simple. Right? ليش عندنا هيك change with blood volume? And why do we have this change in TPR? Again, in TPR, the systolic change is similar to that of the positive and negative inotropy. But an increase and decrease blood volume, ما عندنا the same change. Why is that? Because نرجع للvenous return curve. طيب, in the venous return curve, احنا شو حكينا أول إشي about the MSP? What was the MSP? The pressure of the vessels in what state? Heart stopped or in a dead person. صح ولا لا؟ قلنا كمان it's nearly equal to the venous pressure. صح ولا لا؟ ممتاز. طيب, in a dead person, he's dead. How can I increase the pressure in his vessels? Two things. Huh? More blood. So what does that do to the MSP? It increases the MSP. صح ولا لا؟ ممتاز. Okay. هلا let me relate the MSP to the venous return curve. طيب. Let me think of how I'm going to explain this because I forgot how I explained it in the Huh?
It's the pressure, the definition of MSP, it's the volume, the venous return when the right atrial pressure is 0.
Oh, صح but I forgot exactly.
Wait, what did you just say? You said when you increase the blood volume,
Okay,
the
صح.
MSP will increase?
Yeah. It will.
The curve says the opposite.
لا the curve says the same thing. شو بصير لما يصير increase blood volume؟ شو بصير؟
Increased blood volume, the MSP is the same.
هلا I'm gonna explain the MSP for you guys to understand ليش it
Sorry.
increases. Okay, I can't write this. مش مهم. طيب, let's imagine مع بعض. طيب, قلنا ال MSP is equal to the vein pressure صح ولا لا؟ ممتاز. طيب, وقلنا إنه for there to be venous return, the right atrial pressure has to be lesser than the venous pressure. Can we also say that the right atrial pressure has to be lesser than the MSP?
Yes.
Yeah, because they're the same pressure. نفس البريشر. هو في الآخر أصلاً MSP معناته in other words is the venous pressure. بس يعني coincidentally we found out in the MSP طلع نفس البريشر تبع الفينز. again, can we say that the right atrial pressure, the MSP is the same as the venous pressure? حكينا هاي already we established why it is the fact. صح ولا لا؟ ممتاز. And then we said an increase in the venous pressure has to be there and a decrease in the right atrial pressure for blood flow for venous return. صح ولا لا؟ can we change this idea into saying no, we need a lesser right atrial pressure and an increased MSP?
Yes.
Can we say that? ممتاز. هو اصلا it makes sense. ليش؟ شو يعني ام اس بي؟ يعني the mean يعني the mean الام اس بي كان mean systemic pressure حلو of the whole body. وطبعا for the right atrium to be able to return back blood it has to have lower pressure than the rest or the average pressure of the whole body. This is what MSP means, صح؟ إنه ال MSP معناته the average pressure of the whole body in a dead state it has to be higher than that of the right atrium. يعني معناته in other words in a dead patient إذا right atrial pressure تبعه كان أقل من ال MSP تبعه حيكون في عندنا venous return ولا لا؟ patient ميت. ممتاز. هي هالفكرة. صح؟ let's focus on the idea of يعني what does this mean? What it means is simply is the right atrial pressure has to be lower than the MSP for there to be venous return. In other when يعني okay let me ask it in this way. If the right atrial pressure equals the MSP شو بصير في venous return? What's the quantity? Zero. MSP equals RA شو الكوانتيتي تبعت venous return? Zero. Where in the y-axis هون عندنا venous return zero. ممتاز. كذا. طيب and then we go back يعني احنا قلنا ايش؟ انه venous return equals zero when the right atrial pressure بيساوي MSP. This line tells us شو right atrial pressure صح ولا لا؟ ممتاز. At zero right atrial pressure equals this amount. فمعناته what also is this telling us? This is also the MSP. You understood this point?
Yes.
You understood why? Okay. You understood why this is the MSP? بس بروح قدام برجعش. طيب. You understood why this is the MSP? فهمتوا ليش؟ شو معنى؟ طيب. يعني في حدا ما فهم why the MSP is the intersection between the line and the x-axis and the x-intersect equals the MSP. طيب. I know it's a bit يعني confusing because there's a lot of graphs and maths in it. طيب. But if you follow the logical trend, what we're trying to say is right atrial pressure has to be lower than the MSP or the venous pressure for there to be venous return. صح ولا لا؟ ممتاز. هلا when we have no venous return معناته the right atrial pressure and the MSP بيساووا بعض. ممتاز. Venous return in the y-axis is zero, which is the line of the x-axis. Look at the graph. Look at where the line intersects with the x-axis, which in other words means the venous return بيساوي zero. This point tells us how much the right atrial pressure is. We said in the right atrial pressure بيساوي ال MSP. It equals the MSP at zero. فمعناته the right atrial pressure equals the MSP at this point. And then we also said that the MSP increases in a dead patient how? By increasing volume. Therefore the x-axis shifts. This is why the x-axis shifts because the MSP increases when we give blood volume. Because again the MSP طيب بيساوي right atrium بيساوي the right atrial pressure at a systolic volume of zero. هلا in the case of TPR in total peripheral resistance here we're not giving fluids. طيب in other words a patient with increased يعني you know he has a what's it called vasodilation or vasoconstriction. طيب if we kill him while he's vasoconstricting or he's vasodilating his MSP would stay the same whether he was vasodilating, vasoconstricting or none of the above. I know this confused a lot of you guys يعني I actually want to write it down for you guys to understand بس إذا عن جد ما فهمتوا هالنقطة I want you to come back to me after the class or I want to يعني revisit it طيب عشان it's actually a very important point for you to understand what the MSP has to do with the whole graph. Because when you understand the MSP you will understand the difference between the changes in this graph and this graph. طيب بس simply speaking طيب is لما حكينا احنا انه ال MSP بيزيد بالبيشنت لما نعطيه in that patient when we give him fluids. طيب what we're trying to say here is ان the x-intersect اللي هي اللاين لما تضرب ال x-axis تتغير حسب الكمية الفلويد اللي نعطيه. طيب if you give him a lot of fluids the x-intersect increases or decreases accordingly. طيب I know a lot of you guys are confused on هالشغلة.
One question. Can we say in the MSP is equal to the right atrial pressure لما يكون venous return zero?
Well, this is the how we established and yes this is the case.
And they are all equal to zero?
لا. It doesn't matter how much they're equal to. Whether they're zero or more في الأخير إحنا متى بصير عندنا venous return لما يكون عندنا pressure difference.
Yeah.
لما مثلا الرايت atrial pressure كان 6 والام اس بي كان 6 حيكون عندنا venous return بس هي مو زيرو صح ولا لا؟ فthis is the idea انه لما الام اس بي بتساوي الرايت اتريال بريشر ما بكون عندنا فينس ريتيرن، البلد بيثبت، فالفينس ريتيرن فاليو زيرو، بس at the same time the pressures are equal. فمثلا if I can measure the right atrium, this فورا tells me انه the MSP pressure is whatever I measured in the right atrium. وهون هي هاي الفكره تبعت هالجراف انه اذا we look at the venous return curve, when the venous return is zero, we just go back and we see that the right atrial pressure is equal to that of the MSP. But therefore يعني this graph صراحة as much as I would like to explain it احفظوها طيب من الآخر طيب it's a very simple one. When we have increased TPR, the cardiac output decreases by neither decreasing the blood volume nor by giving negative inotropy. بس إنه again كثير ناس قاتلوا عليها هاي بكورة. طيب I tried my best to find a proper explanation because I never got convinced to why this actually happens. طيب الآخر احفظوها. طيب يعني إذا أجت لكم الامتحان احفظوها. This will never benefit you in clinical years ولا عمرها حتفيدكم بشيء، فبس احفظوها. yeah, you know, it's a disaster to understand because يعني logically it makes no sense for there being a negative or positive inotropy effect in an increased peripheral resistance state.
Wouldn't it be related to increased afterload?
Okay, let's say we increased afterload. حلو. طيب ممتاز. Wouldn't this increase the unstressed volume? He the whole problem with this statement, this graph, is the unstressed volume. And when we increase afterload, اللي هي مثلا the arteries are constricted. طيب what happens is we have a shift of fluid into the veins. صح ولا لا؟ فالمفروض logically speaking إنه this actually just it shifts it. It's not supposed to stay in the same position. In other words, the MSP has to change here. بس إنه الفكرة إنه because we're not adding fluids, it makes no sense for it to change, but it has to change because there's more blood in the veins than there is in the arteries. فالMSP المفروض ما يكون نفس الشيء. If I go into the explanation of what I understood هون, it's a disaster. Just memorize it. أهم شيء تفهموا هاي وهذيك بس. هاي simply positive negative inotropy يعني the contraction of the heart خف يعني صار ضعيف. وهون the blood volume قلنا إنه it relates to the MSP. إذا MSP بيساوي right atrium معناته there's no venous return. And how would we know that there's no venous return? We look at the venous return when it's zero. That's how we know the right atrial pressure has increased or decreased depending on the MSP. يعني إنه the MSP increases in inducing of blood volume. So therefore it would shift the x-axis. Again, if this idea أنتم ما فهمتوها, please come back to me for me to explain it again. It's gonna get a bit too confusing for you guys. I don't wanna overstay on it. Done. Okay, we will explain. Okay, what does this graph represent? شو المشكلة عندنا هون؟ هلا I want someone just to explain to me what he's looking at يعني وشو عم بيصير هون. What's the changes? Of course, the changes is the dotted lines.
Can I?
Yes.
Okay, so the Starling curve or the contractility curve is shifting على right. So that means increased contractility.
لا, the dotted lines are the changes.
Yeah.
طيب صح.
صح.
Shifting downwards يعني.
Shifting downwards يعني increased contractility.
I mean decreased contractility.
Okay,
Decreased contractility, yeah. It's shifting downwards, yeah. Okay. بعدين the vascular function curve, it's shifting right كمان. That means increased blood volume. Decreased contractility مع increased blood volume, that indicates heart failure.
What type of heart failure?
Systolic heart failure.
Okay, good. Did you guys hear what she said? Okay, now let's explain why this happens. But systolic heart failure is simply any problem that the heart faces that causes its systolic function to become disastrous. حلو؟ ممتاز. هلا when it becomes disastrous شو بصير عندنا بالسيستوليك فانكشن تبع الهارت؟ قلنا شو بصير بالجراف الاحمر؟ طيب decrease it goes downwards هون. طيب it goes downwards. Negative inotropic effect. Because again يعني مثلا a patient with multiple MIs طيب من الاخر his left ventricle ماكل هواء كله fibrotic بطل عنده left ventricle. In other words his inotropy is negative as it is. ما في داعي we give him drugs ما في داعي we do anything to the guy. He has negative inotropic effects induced into his heart due to multiple ischemic attacks. But it reaches to a point where the systolic function is extremely dangerous. But at this point, we start calling this condition as heart failure. And the heart is failing to do its job. What type of heart failure? Systolic. Okay? So first of all, heart failure is induced in a patient with a bad heart condition. يعني heart تبعه خربان. Right? This, in other words, means weaker myocytes, and as we see it in the systolic curve, it goes downwards. Right? The weaker myocytes means lower cardiac output. If you look at this, طيب, and look at it in the original venous return curve, not the new venous return curve, and the cardiac output شو؟ Okay. It had ما مسوي شيء يعني.
I think you're sure.
ايش شفت ايش مش لابس It's decreased صح ولا لا؟ ممتاز. How does the body compensate? أول شيء, what is the first organ that senses this change? Kidneys. What does it do? RAS, RAS system, renin angiotensin aldosterone system, goes into action. What does the body do? It produces aldosterone where it causes retention of sodium and water. So what does this cause? And what does it do? It shifts up the venous return curves. صح ولا لا؟ ممتاز. Did you guys understand these 2 points?
The venous return is shifted because there is maybe resistance due to the RAS system.
هو الراس system شو بيسوي؟ What does aldosterone do in the end?
Vasoconstrictions.
Not really. هي مش مهمة تبع. هي صراحة this is why كمان it shifts شوي. Someone say something? Okay. This is why it shifts a bit. بس إنه in the end the main change اللي هي water and salt retention. Therefore كأنه إحنا عطينا واحد bolus fluids. يعني as if we give a person fluid into his body. So what happens? The x-axis shifts and takes everything to the right and up. Right? This is what's happening بالضبط. Right? It shifts up and a negative inotropic effect. In other words, what we're seeing here is systolic heart failure. Right? Let's go on to talk about heart failure. In systolic heart failure, if it continues this way, should first symptom will we see?
Low cardiac output.
Symptom. كيف نشوف
أدنى.
وين؟
شو اسمه بال.
كيف نشوف hypertrophy?
pulmonary أدنى.
How do you see
X-ray.
hypertrophy? هو بيجي حيجي يقول لك سوي لي اكس راي hypertrophy؟ ها؟ هي صح dyspnea or sorry in edema صح؟ Where؟
pulmonary أدنى.
ممتاز. Who agrees with her? Why guys عادي يعني you can agree by the way أنا مش عم بخبطها. Who agrees with her?
كويس مالكم.
Who disagrees with her? Who says something else? قول عادي إذا في حد عنده فكرة ثانية.
The first symptom,
Yeah.
wouldn't it be increased heart rate?
عادي I have increased heart rate I have heart failure.
Or generous.
No, but we.
لا no specific symptom that actually يعني he comes in and you think he has heart failure. عادي okay dyspnea is good. But is this correct? Not really. ليش؟ ها؟ ليش? I need someone to. Did you guys study heart failure?
What are you asking?
I'm asking you why is dyspnea not the right answer? It is correct. Only half correct.
Why are you sleeping?
Well, this is dyspnea again. It's orthopneic dyspnea. كله صح. So why is it not correct? طب مثلا إذا عنده right sided heart failure, systolic. What does it?
يكون systemic symptoms.
Which is?
Wait, what are you asking exactly? You're asking for.
معناته dyspnea is not the only symptom. طيب. هلا why does everyone say dyspnea?
Oh my goodness.
تعال. I'm just messing around with your heads. طيب. Why do people usually say dyspnea? Because it's the most common. What's the most common? Left-sided heart failure, جماعة please يلا. Left-sided heart failure that is systolic in function, right? Or also known as HFrEF. طيب. What is the second most common? اللي ضل. شو اللي ضل? Right-sided heart failure. طيب ممتاز. طيب حلو. After that is the case, okay. What is the most common cause of left-sided heart failure?
Pulmonary.
حتى أنا ما بعرف. هو غالبا I think it's hypertension or multiple ischemic attacks, but even I don't know.
Yeah, it's.
But the question I'm trying to get to is what's the most common cause of right-sided heart failure?
Pulmonary.
Right?
No, left.
He said it first.
Left is left.
Left-sided heart failure. Right? In other words, a patient with a standing left يعني واحد عنده دائما عنده left-sided heart failure شو بصير؟ His systolic function is not working properly. Right? Again, the reason I'm saying systolic is because usually 99% of the times you're always going to see systolic heart failure. Diastolic heart failures are in specific type of diseases. We're going to talk about it in a bit. But in systolic heart failure, which you're going to see most of the time in the ward, right? You're going to see systolic heart failure, and after that, after seeing them, hello, they're going to come with dyspnea, and this dyspnea is going to cause congestion. When the congestion starts on the left side, it will congest the lungs, which then congests the right side. The right side is congested; it no more can يعني بطل الرايت سايد بيقدر يسوي systolic function because whatever it's pumping is staying in the right side, so the right side becomes failing heart. Therefore, this failing heart will then present as peripheral edema. But who knows, except Sami, how a patient with heart failure presents in the emergency. طبعا بيجي emergency ما بدخل على الكلينيك يا دكتور عندي heart failure. Come to what the first thing he presents with?
Syncope.
Not syncope, لا. Syncope is MI.
Tachycardia.
أو aortic stenosis.
Tachycardia.
ها؟
Hypertension.
يا جماعة أنتوا عندكم تاكيكارد تروح المستشفى؟
Hypertension.
لا. ها؟ إدمة وين؟ ديسني. تخيل imagine you're suffocating underwater. That's exactly how they feel. يعني تخيل أنت you're literally swimming in water. That's exactly how they feel when they have dyspnea due to edematous lungs. They will come complaining of edema. طيب؟ هلا let's imagine إحنا مشينا على emergency ward وشفنا patient and you want to say that this patient has heart failure. What would you see? How would they present? اسكت. طيب ها.
Pulmonary edema, when you percuss,
You see pulmonary edema
when you percuss the lungs, it will be.
You're gonna go to any patient and be like, there's actually something you're gonna see that is so different. Oxygen mask, that's one. It's three things. Oxygen mask, correct?
Nitrates.
Usually patients
Nitrates.
No.
Sweating?
سويتي كل حد سويت.
Syncope نايم.
مش سنك. لا هذا غلطة.
مو نايم.
بالضبط exactly. That's actually the thing.
شو.
Everyone in the emergency is bent down in this bed. The one patient you will see sitting upright with an oxygen mask. That's two. Third thing, how do we treat heart failure, especially in a dyspneic? So exactly what would they have?
حيكون كافة.
مو كث مش كل حد يحط له كث.
يعني هي هاي.
But they're gonna have a peeing bottle.
أيوة.
The three things. A peeing bottle, they will be sitting upright and they'll have an oxygen mask. Why is that? Let's explain every idea and everything we just saw. Sitting upright because if they're gonna sleep, they're gonna suffocate. But oxygen mask because they're already suffocating as it is. So we wanna make sure the air they're breathing is 100% oxygen so they can supply the body. But and third thing is a peeing bottle because in a dyspneic attack, right? We need to شو نسوي أول شيء to remove the fluids in his body because us أول شيء why is fluid being built up in his body؟
Because the heart's not pumping. It's building up in the heart.
مش عشان it's building up ده ليه
Congestion ما في pumping.
So why is there congestion؟ احنا حكينا yes because of the RAS system. The RAS system continues to work because the RAS system is stuck in the point where it says إنه systolic function مش شغال and I'm not getting oxygen يعني I'm not getting blood as يعني the kidney says I'm not getting blood يلا دخل more blood to the point that the lungs become congested because the heart is not pumping blood to the kidneys. حلو؟ So what do we give? We give diuretics. يا كدني اسكتي اقعدي ويلا كبي مي. طيب patient please. You know what diuretics do we give? صراحة he didn't study. It's called Lasix. الله عليك الله. I wonder who taught you. طيب furosemide. طيب furosemide you're gonna study inshallah the kidneys. I really don't يعني it's always been a complaint by me no you should have studied diuretics and cardio because it makes more sense. طيب وهلا we're gonna go into another topic. Usually patients with heart failure they present with what?
Sinus.
Actually, before we go into this, let's look at the graph. حكيت عنها رح ندخل عليها. Okay. Can you see this graph? اللي هي systolic function of a negative inotropic. In fact, this is not really negative inotropic. It's actually more heart failure. طيب. Let's explain it in a systemic way. A patient can come in any point in this graph. صح ولا لا? He can present here. He can present here. He can present here. صح؟ ممتاز. If a patient presents here يعني على التحتاني what should I do to enhance his cardiac output؟
Positive inotropic.
لا positive inotropic بيموت ما الهارت تبعه is not pumping. He's here. What do I need to do to preload؟ هون عم ينزل decrease. For what do I give؟ حلو. This is what you do in heart failure صح ولا لا؟ I give diuretics. Patient is good. But if the patient came here what are we supposed to do؟
Reduce after no.
Positive inotropic.
A positive inotropy is correct always because it's gonna increase it up. بس كمان في شغلة هون. We always said it's not just that. We always said in heart failure.
Decrease heart rate.
مش actually forget this point in here. If he's here, what are we supposed to do? Oh no. جماعة, if he was here, we give diuretics. It decreases the preload, pushing the cardiac output up. صح ولا لا?
Fluids.
Exactly. If he's here, we give fluids, pushing the cardiac output لفوق. So imagine a patient was here and we gave him either diuretics or fluids. شو حيصير فيه؟
Yeah.
He's gonna die. And this is the problem with heart failure. فهمتوا the idea?
طب how to manage it شو حنسوي؟
Exactly, how to manage it. طيب وهلا we're gonna go into another point. Subhanallah, heart failure, the patient has to be in a strict volume and they have to be strictly taking care of his volume ليش? Because exceeding the volume point can be very problematic because it will increase his congestion, letting him to go into edema وهالمصايب الثانية. While decreasing the fluid in his body, طيب, can also do the same exact effect. فمثلا a patient with dyspnea, is his fluid a lot or a little? بالضبط a lot. ولا how did dyspnea even happen? صح ولا لا? You understand this point? Dyspnea is a good indicator and edema is a good indicator and the patient is overloaded in fluid. In other words, in this graph you will be right here. So what do we do? We give diuretics, decrease the fluid. But a patient with regular heart failure, طيب, أجي على الكلينيك مثلا, I have heart failure and I'm taking this diuretic, طيب, but he is complaining without edema. Sometimes we should think maybe over here. So what are we supposed to do in this instance? Give fluids. Two separate things in the same disease can literally kill or save a life. It's only because of the function of the heart. Let's add another layer on top of this very amazing disease. And this is now the question. Patient with heart failure usually presents with what? مش cyanosis. I'm not saying a symptom, another disease. Hypertension, which is the most common cause of.
That's ventricular hypertension.
لا you didn't study this system, so I'm not expecting you to know it.
Her brain absent?
Not really. Hypertension, شو أكثر organ that gets damaged due to hypertension? Kidneys. Exactly. So they come with what? Chronic kidney disease. هلا شو مشكلة chronic kidney disease? The filter, يعني kidneys, how does the filtration in the kidney work? You need a high GFR. GFR simply meaning a lot of fluid that it's exactly, if I'm going to describe it in very simple terms, عشان تغسل ايدك, for you to wash your hand, you need a lot of water. The more the water, the cleaner the hands. So the more the fluids in the body, the better the kidney function, the better the شو اسمه انه مش بس output انه هي الفلتration. طيب exactly. حلو. In the heart, in the other side, in the other term, right? The more the fluid, the worse. In the worse, in heart failure specifically, the worse. For in heart failure, what are we giving? Diuretics. But if we give diuretics, شو بيصير بالكدني? فوق الهواء. And it literally and it kills the patient. Right? So we're supposed to give fluids. So in a heart failure CKD, what are we supposed to do? In heart failure, we're supposed to give diuretics, remove the fluid to make sure the patient doesn't go into dyspnea and fluid overload. But at the same time, while we're doing that, we're killing the kidneys. Because the kidneys need fluid to filter. We're supposed to give fluids. But if we give fluids, the heart will fail and die and the patient will go into dyspnea. What are we supposed to do in this two specific
Can we give moderate dose dopamine?
Huh?
ACE inhibitors.
It's actually not a specific drug. Huh? It's not a specific
and
drug.
You want to increase GFRs at the same time maintain the pressure in the kidney.
It's not the pressure in the kidneys that's making it worse. It's the actual fluids. The amount of fluids اللي بالجسم لازم يكون كتير. To cut the shit short, I'm not expecting you guys to know it. It's called the cardiorenal syndrome for a reason, because this is a disaster. This is the reason أصلاً the stereotype between cardiologists and nephrologists hating each other is there. It's because of this specific condition. When a patient presents with chronic kidney disease and heart failure, بدق في بعض, because literally this happened in my hospital. It happened in the hospital I was in. A patient, the cardiologist بيحط diuretics, the nephrologist بيشيل diuretics. بيجي الكارديولوجيست مثلا بيحط diuretics. Nephrologist بيجي بيشيله. in the same instant of an hour شالوها 6 مرات. شالوها بس حطوها 6 مرات. الاي سي يو دكتور البيشنت كان بالاي سي يو عصب قال شو هذا مسخره اولاد صغار عم يتضاربوا. جيبوهم الاثنين خلينا نحكي عن الموضوع. The way they actually treat these patients. SubhanAllah, the patient who had this, by the way, was a nephrologist. It just adds more details on the whole thing. طيب اللي بيضحك انه how do we treat this? Alhamdulillah, because the patient was a nephrologist, he even knew how to deal with this case. He has to measure exactly to the milliliter how much he outputs and how much he inputs to the milli. Because there's only such a small window where his body would have good heart function and good kidney function. Increase it a bit, or the heart fails, decrease it a bit, and you will have Uromic syndrome or Khabisa, the CKD will go haywire. This is why it's called the cardiorenal syndrome, because it's an extremely multidisciplinary يعني انه شو اسمه management, and it's actually very interesting if you go read it if you're like interested in the cardio section or the renal section. It's very يعني interesting صراحة. It's called the cardiorenal syndrome. In Ambos it's actually written in a really nice way. It tells you how CKD with مثلا heart failure, how AKI with heart failure, how just normal kidney function with heart failure, how they're all differently treated and how they're differently managed. It's very interesting, and now we understand lesion heart failure is a very hard thing to manage because overload and low amount of fluids both can kill a patient because both are needed. Huh?
Is it common on all the cases or is it like just
He specifically بالcases اللي يكون عندهم kidney disease and heart failure, which is usually most of the cases. يعني عادة الإنسان يعني the most common cause, or at least one of the most common causes of heart failure is hypertension, or the most common cause of chronic kidney disease is hypertension. A patient with hypertension who's not controlling it properly هيجي بالثنتين. فبصير عنده خبيصة. يعني هي الفكرة. طيب. Okay, guys. Look at the graph. بس يعني analyze it على السريع. Again, the dotted line is the changes. The dotted line is the changes. We're gonna now look at the question, and I want you guys to answer. What do you think the right answer is? Did everyone understand this?
Yes.
Okay. Which of these are the causes? شايفين ولا لا؟ Do I go to the choices?
What is that?
طيب who thinks it's chronic anemia? Huh? Who thinks it's hemorrhage? Who thinks it's exercise? Who thinks it's bolus lactate ringer? What is bolus lactate ringer? Lactate ringer is fluid, by the way. طيب look, lactate ringer is simply best fluids. Bolus يعني it's a huge syringe, fast infusion of a big syringe. Myocardial infarction. It could be. طب anaphylaxis. شو it could be؟ يعني شو انت ما رفعت ايدك على شيء.
يعني ما اقتنعت فيها بس هي
طيب it is MI. ليش ما اقتنعت؟
انه مش دائما بتاثر على الكونتراكتيليتي على
حسب كميتها صح؟
اه
اذا بس شخطه لا صح؟
الفايبروسس
بس اذا كل اللفظ
اذا صار في فايبروسس
ماشي.
لا صراحه اذا شخطه او كله it will affect because if you lose one cell in the heart it is a primary يعني ايش كان اسمه؟ انه it doesn't regenerate. كان اسمه السيلز that doesn't regenerate. مين ده؟ ها؟ permanent. It's a permanent. And if you lose one cell نكتب هنا تروح على السريع. عشان هيك don't go into an MI. فيا MI is the answer. طيب how does hemorrhage present? What will happen in hemorrhage? Wait. أنا سمعت 10 أجوبة. Say it.
So the venous return will also drop if there's hemorrhage.
Only hemorrhage.
Only hemorrhage. Both will drop. Cardiac output and venous return.
ليفت شيفت اوف ذا فاسكولار فانكشن.
خالد يا أخي جاوبت كثير. It's not both of them.
just the venous return?
It's just the venous return. بس. السيستوليك function تغير ولا لا؟ hemorrhage. BMB ما بعرف يشرح الموضوع. أنا اكتشفته خلاص. Guys, is hemorrhage decreased blood volume? Yes or no?
Yes.
When it decreased the inotropic? Where is it increased?
Not necessarily here, it's multi-systemic.
Okay, حلو. أنا قصدي إنه decreased hemorrhage يزيد السيستوليك. Okay. Well, this is the problem. This is the problem with this curve. Is إنه are they talking about after compensation? لا أنا بس قلت hemorrhage. I'm not talking about after compensation. What? أول ما تخسر البلد فورا حيصير عنده هاي contractility. لا. This is do not jump. طيب just follow what يعني is needed. Hemorrhage يعني decrease blood volume يعني left shift of the venous return curve. طيب بس يعني هي طيب أو مثلا bolus lactate ringer right shift. طيب chronic anemia this هون تقدر تحكي عن الcompensation. ليش؟ because we said chronic anemia. You understood this point? In chronic anemia guys this is actually really nice. Chronic anemia شو بصير عندنا? Who knows?
Polycythemia. No, or just
Chronic anemia. Chronic anemia.
Heart rate increases.
Increased
ها؟
Contractility will increase.
حلو فعندك السيستوليك بيطلع فوق ولا تحت؟
فوق.
فوق ممتاز that's right what else؟
Venous return
شو بيصير فيه؟
Increases.
Increases.
ليش؟
Polycythemia may try to compensate the loss.
هذا كله عنده انيميا ما عنده بوليسيثيميا. You cannot say polycythemia is عنده anemia.
because
increased
there's
venous.
It increases but there's another reason.
But
decreases.
there is
Increases.
more
To move the compliance, to shift compliance.
How would it do that?
Constrict the venous.
Not really. It actually doesn't even increase يعني. It actually increases just slightly for a very يعني شيء سخيف جدا.
Venom secretion.
ها؟
Venom.
لا لا. يلا chronic عندك anemia what happens to the blood?
Venous.
بالضبط it becomes less viscous it becomes easier to take back. That's literally just a slight increase in the venous return. طيب؟ So again this is يعني overdue for you guys ما في داعي تعرفوا لهال details. Anaphylaxis شو بصير عندنا هون؟ What? Again, in anaphylaxis, what is the first change? The right, the systolic or the diastolic?
I think that's
طيب حلو، اللي قال systolic ليه والحال diastolic ليش؟ شاهد ليش diastolic؟
أنا جاوبت كثير.
You said systolic، ليش systolic أول change؟ But that changes what diastolic or systolic?
TPR, it changes both.
Systolic or diastolic يا جماعة؟ ما بدي both، ما بحب جواب both.
It does change both.
Anaphylaxis, what does it do?
Vasodilation.
Histamine.
What would that change?
Venous return
Venous
will
return.
drop.
What happens to the venous return?
To
It drops. صح. But you're going to the left. Compensation شو بيصير عندنا؟
Cardiac complications.
طيب that's nice. So again, this is it for the health. And we go into the congenital heart diseases. Did everyone understand the systolic and diastolic functions? طيب how many functions are there in the heart هلا جاي لك؟ شو هم؟
systolic and systolic.
يا رب نفهم هاي الشيء. If there's one thing I want you guys to understand is this thing. The heart has two functions مش one function. Systolic and diastolic. Yeah, شو يعني؟
الانافيلاكسيس
ايه
مش بيسموها سيستميك فازودايليشن
حلو.
مش المفروض الجراف يكون نفس الديكريس تي بي ار.
لا يا اخي انت مشكلة يا اخي مشكلة يا اخي لا بس شوف الفكرة هون انه although يعني هالسؤال جايبه من نيو وورز انا طيب صح لازم يكون زي شو الانكريز ولا ديكريز تي بي ار؟ ديكريز فلازم يطلع اثنين لفوق صح؟ انا شو قلت لك عن هالجراف؟ احفظه عشان الجراف سيء جدا ما يعني it makes no sense. طيب الانفلاكسس makes sense. الانفلاكسس ليش بصير عندنا فينوس ريتيرن اقل؟ الانفلاكسس ليش بصير عندنا فينوس ريتيرن اقل؟ بصير عندنا فينو دايليشن طيب البريشر تبع الفينز دروبس بصيروا اوطى من تبعون الرايت اتريم فبقل الفينوس ريتيرن صح ولا لا؟
طيب
ممتاز اشرح لي اياها ليش ديكريس تي بي ار ده بيقل؟
بس انا هون اللي فهمته الكاردياك فانكشن كيف لما انت مثلا خلينا نحكي انكريز تي بي ار لما تزيد تي بي ار بيزيد افتر لود مور ريزيستنس بيقل ستروك فوليوم والكاردياك اوتبوت
اوكي
فبيقل الكاردياك فانكشن.
حلو هذا معناته انه اوكي نكتب اناتروبيك
في نفس الوقت لما يقل الستروك فوليوم يعني يقل الفينوس ريتيرن فباسكولار فانكشن كيف كمان
معناته if that's the case معناته النكتب اناتروبيك المفروض دائما الفينوس ريتيرن المفروض ينزلوا مع بعض فاهم علي؟ انت ليش الفينوس ريتيرن اقل من وراء الكاردياك اوتبوت؟
والله هيك فسرت يعني لانه الجراف هيك.
ما حلو انت قلت لي انه ذا انكريس تي بي ار قل سوى نكتب اناتروبيك افكت على الهارت يعني نكتب اناتروبيك على الهارت قلل الكاردياك اوتبوت عشان هيك قلل الفينوس ريتيرن صح ولا لا؟
لا الكونتراكتيليتي ضلت نفس ما هي بس الفكره انه الانجكشن فراكشن قاعد يقل لانه مور ريزيستنس.
طيب بعدين معناته قلل الفينوس ريتيرن من وراء الديكريس انجكشن فراكشن يعني؟
ما هي
حلو احنا هون ما عندنا ديكريس انجكشن فراكشن بالنكتيف اناتروبيك عندنا صح؟ ليش ما قلل الفينوس ريتيرن؟ هاي المشكله الانكريز ديكريس تي بي ار اي بروميس يعني الناس تذبحوا بعض.
الفينوس ريتيرن قل بس الجراف ما تغير يعني الستيدي ستيت بدل ما تكون مثلا 5 لتر صارت 4.5.
حلو ممتاز. طيب ليش هون الستيدي ستيت قلت بالجهتين؟ يعني شو من الاخر when we say increase and decrease تي بي ار تعرف انت عن ايش بنحكي؟ عن اي فيسلز؟ arterioles بس that's it. arterioles هم الشيء الوحيد اللي increase and decrease تي بي ار شو خصهم بالفوليوم؟ بالبلود فوليوم بالفينس ريتيرن. In everything we said شو لهم دخل؟ What do they have to do with increased venous return?
decreased blood volume هيقلل الفلتريشن هيقلل البلد فوليوم.
وين decreased blood volume وين؟ بالفي ليه؟ Why would the venous return decrease if I just literally contracted the arteriole? فاهم؟ These things have been talked about. وين؟ كيف less volume؟ less volumes are going ليش؟ عشان يعني في increase فالبطل يروح صح؟ ممتاز. هو حكى نفس الشيء قال انه الكارديك اوتبوت قل من ورا increased تي بي ار فقلل venous return عشان احنا حكينا انه الكارديك اوتبوت والفينس ريتيرن has to be equal. ليش النيجاتيف اينوتروبيك افكت ما بيقل عندنا الفينس ريتيرن؟ اذا we use the logic نيجاتيف اينوتروبيك افكت مش بيقلل الكارديك اوتبوت، طب ليش ما قلل الفينس ريتيرن؟ هو لحاله بيقل من الاخر، هو لحاله بيقل. الفوليوم نفسه ما بيقل. هون هلا ما هي الفكره انه شو قصدهم بهالشيفت داون تبع الفينس ريتيرن، هي الفكره بس. The only thing that shifts this down يعني shifts this down is انه for some odd reason البلد at the same يعني في نفس البريشر ديفرنس قل روحته يعني قلل سرعته بس. فاهم الفكره وين؟ In other words الانيميا، ليش زاد الانيميا؟ ليش شرحت لكم الانيميا زادت؟ thinning of the blood خلت يعني خلت البلد سلسل. فانت تشوف الجراف تبعها it actually doesn't shift، ما فيها shift. it just goes up a bit. ليش؟ سرعه البلد خلتها تزيد. عشان اذا انت بتفهم الجراف صح what the graph is trying to say is in the same difference of a normal patient, a patient with anemia's blood runs faster. How does increased TPR do that? Because the increased TPR, decreased TPR بيسوي نفس الإفكت صح ولا لا؟ أنت فاهم ليش الناس كثير متأكدين عليها؟ هي بقول لك بالآخر احفظوها لصالحكم. أنا فلاكسس بيشرح يعني this graph actually explains what is supposed to do, what is supposed to happen in venous vaso and venodilation. Right? Vasodilation generally, vasodilation كله. This is what's supposed to happen. No, it just affects it just affects the venous return. طيب عشان again الفرق بين increased decreased TPR و vasodilation is vasodilation عندك الفينز دي dilate. and increased TPR it's simply بس الارتيريولز اللي عم تتغير اللي هي increased TPR بصير في عندهم contraction و decreased TPR increase. المهم نحكي عن الموضوع لما نخلص عشان ما I don't want to lengthen the lecture بس نحكي عن الموضوع بعدين. بس الشرح انا this is why I left it يعني انا من الاخر ما فهمت راسي شو طيب congenital heart disease. طيب my favorite topic wow. طيب right and left shunts, right to left and left to right. طيب اي واحد بيعطينا ساينوسس؟ اي واحد بيعطينا ساينوسس؟ right to left. Does everyone understand this point? And why does sinus happen from right to left and not left to right? Right to left اللي بيصير عندنا انه left side is going to the body, right is going to the lungs. Whatever blood I send to the lung مو مهم. But if I send blood to the left side اللي هي systemic pressure that is deoxygenated, it will show us cyanosis in the body, central peripheral اللي هو. طيب this is simply what it is. And then we have the Eisenheimer syndrome ما بعرف شو اسمه. طيب Eisenheimer syndrome. طيب Oppenheimer syndrome اللي هو يا جماعة. طيب اللي شو بصير عندنا؟ طيب مشكلة I actually want to draw this because it's doesn't work. طيب قال لك نشوف. طيب اوكي فعندنا احنا very nice drawing of the heart. طيب عندنا الرايت سايد والليفت سايد. Who has more pressure? Left side has more pressure than the right side. Okay. If we have a shunt between them, who pushes blood towards who? ليش؟ Because the pressure goes from higher to lower. صح. It goes from left to right. طيب هلا stop this thought. In hypertension شو بيصير بالهارت؟ ليش بيصير في عندنا hypertrophy in hypertension؟ It's just simple adaptation. بالضبط. It's just adaptation. إذا في increased afterload or increased volume, the body adapts by increasing the size of the heart. Simple adaptation. Increased volume or increased afterload, the heart adapts with increased size. The right side or the left side now has more blood in this shunt. Right side. But what does the right side do? Hypertrophy. معناته the pressure in the right side will do what? Start to increase. طيب شو بصير هلا مين بصير عندي شفت وين؟ بصير right to left. شو بصير عندي؟ What's the first symptom that we see? Cyanosis. This is what Oppenheimer syndrome is. اسنجهايمر اسنجهايمر ما بعرف شو اسنجهايمر اللي هو طيب simple طيب easy صح ولا لا؟ Very basic طيب هلا there are heart defects. There are two types of heart defects. Either they come with a right to left shunt, either they come with a left to right shunt. ممتاز؟ That's good. Look at them. طيب transposition of the great arteries. This is going to be good. طيب transpositions of the great arteries يا جماعة الخير. طيب شو مشكلة الترانسبوزيشن؟ شو مشكلة؟ بالضبط. ال right side صار literally only يعني to the lungs and back from the lungs and to the lungs and back. بالضبط. And the left side will actually العكس. Which side is to the lungs and back?
Right is systemic, the left is systemic.
Right? Which one is systemic? The right side or the left side? Well, the left side is pulmonary. حلو. طيب it's easy. What's the problem? What is the يعني هذا neurological problem? Trunkus arteriosus شو بصير فيه؟ It doesn't spiral. In other words, what is the problem and what type of cells? الذكي بيعرف شو هو. You studied last year.
It's the box هذا المسؤول عن
لا Trunkus arteriosus, their cells are originates from what type of cells?
Mesoderm.
Wait, it was more than E?
لا you studied last year but no one got a ما واحد انتبه.
Question? What's the question?
The Trunkus arteriosus cell, specifically the septum that separates both the great arteries, comes from a specific origin embryologically. What are they? وين كمو neural crest صح you took it last year رحت رابع neural crest cells. طيب هلا another question again because another question طيب because again you guys know what great transposition of the vessels are. Patient انتوا عارفين you do an echo while he's in his mother's uterus. He's gonna come out with transposition of the great vessels. What do you give him to save his life?
Transfusion of prostaglandins.
شو من درس يا اختي؟ We took it but بس نص دفعتكم ما بيعرفوا. Okay why?
It's in hospital.
To keep the ductus arteriosus open.
طيب ممتاز. Okay صح. A patient with transposition of the great vessels we give him PGE because we want to keep the PDA open. طيب? Oh, one more thing. Okay, this is good. This is a normal chest X-ray. طيب, we're gonna study more about it. Inshallah, I'll try to make a class for chest X-ray for you guys. طيب. What I want to simply explain is this is the silhouette of the heart. What is the silhouette? طيب, it's the white shadow. يعني can you see what's this area of the heart? أول شيء.
Right atrium.
This the whole thing is the right atrium. طيب. What's this area? Left ventricle and the left atrium. طيب. When we see both sides, we call it the silhouette. Why is this important? Because what we know, if we look at the mediastinum from a lateral point of view, we have the anterior, middle, and posterior. Hello? The heart lies in what area of the mediastinum? حوك الهواء نازل to middle. لا, anterior. It lies in the anterior. إن شاء الله مكتوب middle عندكم
The cardium is the middle.
هو مكتوب. احكي لك الدكتور عمر بالضحك. لا, it's anterior. It is fully anterior كمان.
بس الليجمنتس
ايش هيك كتبت؟ وين تنزل لك تشوز ب1000؟ In the X-ray it's anterior. محلاك كنت تقول radiologist middle عشان يصرف. طيب it is anterior in the X-ray. In your lecture احفظ اللي مكتوب.
He's not gonna believe it. He's just gonna. Okay.
طيب it's in the anterior side. طيب هلا why is anterior مهم? Because there's another disease we see in chest X-ray which is pneumonia. And again this is very out of topic but it's gonna come to you guys in the radio lecture. في pneumonia, طيب, how do we know if it's affecting the anterior side of the lung or the posterior side of the lung? بنشوف إذا في silhouette ولا لا. If I can see haziness in the lung and I can also identify the border of the heart, معناتها ده the pneumonia is posterior. Because clearly there is no overlap between the heart and the pneumonia. But if I cannot see the border of the heart and there is haziness in the lungs, that means it is anterior. In other words, what they call it as is شو اسمه silhouette sign. If there is a silhouette sign, معناته it is not corresponding to the heart. In other words, it's posterior, ورا الهارت, pneumonia. But if it is not, معناته it's anterior, which is at the position of the heart. Again, this is just a يعني increase and another thing that I'm talking about, which is not important. This area is what? What do we see here in the X-ray one? For the pulmonary trunk, the aorta, the superior vena cava صح؟ هون فوق. This is what we call as the mediastinum. لما يقولوا in a vignette when they say widened mediastinum, they mean in this mediastinum has enlarged. What are causes of widened mediastinum? Anyone aneurysm صح.
Dilation of the aorta.
An aneurysm. What else? Something so يعني so easy. في شيء موجود تيومر صح. Lymph nodes. ممتاز exactly that's what I was looking for. Thyroid. Thyroid enlargement. Goiter. It shows in the X-ray as widened mediastinum. But thinning of the mediastinum in great transpositions of the vessels. شو بصير عندنا احنا؟ The aorta and the pulmonary trunk, what do? They flip. For the mediastinum would look thinner than normal. It would look as a lesser mediastinum or a smaller mediastinum. You understood this point? Larger mediastinum معناته يمكن aneurysm, يمكن tumor, يمكن lymph node enlargement, يمكن thyroid enlargement. For thinning mediastinum, usually, especially in a fetal age group, they're actually talking about transpositions of the great vessels. Tetralogy of Fallot. What's the problem here? The infundibulum septum, which is the anterior part of the heart, is and it's narrow and it's moving forward. So what happens is there is overriding of the aorta. There's also what? Pulmonary stenosis or pulmonary outlet stenosis, whatever you study. But there's also right-sided hypertrophy and a VSD. Try to memorize these four all together. من الآخر شو عم بيصير عندنا هون? Right to left shunt or left to right shunt? Why right to left?
Because of ventricular hypertrophy.
بالضبط. The right sided is hypertrophied, plus there's a huge amount of hypertension in the pulmonary area. For the blood would rather go through the systemic than the pulmonary side. There will be right to left. So they will present هيك with cyanosis. What can they do to decrease the cyanosis?
Close this. She opened the stenosis.
مش surgery هم الولد.
Squat.
Why squatting?
Resistance.
Exactly. When I squat, يعني what am I doing to the vessels in my legs? بالضبط. I'm squeezing them, increasing the systemic vascular resistance. By doing that, بصير left side أقوى من ال right side. Pushing, or what we do here is left to right shunting. So usually they will come squatting and they will like هيك يعني بيكونوا ضاغطين على حالهم. هلا what is a TET spell? Simply crying or drinking milk مثلا or eating, where what happens actually is the chest يعني the chest cavity is pressure during crying or eating in these children increases in pressure. Right? Increase in the in the mediastinal pressure or the chest area pressure increases what side, the right or the left side's pressure?
Right side.
Right side. The chest, the lungs and mediastinum and the chest area is right. ليش? Because blood goes to the lungs. صح ولا لا؟ بالضبط. So when I increase the pressure in my in the chest cavity, it increases the right sided pressure, which increases the amount of right to left shunt. يعني right to left shunt بصير أسوأ. بصير شيء اسمه عندهم TET spells. In other words, in a vignette or in a case, you will see them say during eating, his mouth will become blue. مثلا. This is a TET spell that is يعني pathognomonic for شو اسمه tetralogy of Fallot. But what do you see in X-ray?
Boot heart.
Boot shaped heart. Why?
Right ventricular hypertrophy.
Right ventricular hypertrophy. بالضبط. Okay, and then we have يعني هذول أهم ثنتين I think for the right to left shunts. These are the two most important for right to left shunt. The three important ones for left to right shunts are the VSD, ASD and PDA. طيب VSD normal heart بس بيكون عندنا فتحة بالventricular septum. و ASD بيكون في فتحة بالاtrial septum. It can be two different types which are
Septal and post-membranous.
لا هاي for what?
VSD.
The two types of ASDs.
Primum and secundum.
Yeah, primum and secundum. Which is more common? Secondum. Right? هلا for again both of them cause the same thing. In VSD or ASD وما تحكي الجواب. Where do we have paradoxical thrombus more common? VSD or ASD?
ASD.
Who says VSD? يا جماعة VSD has a bigger opening شو هذا؟ طيب why؟ يعني مش حتركوا لحالكم يعني yes it's ASD بس why؟ VSD literally has a bigger opening, but why is there a paradoxical thrombus in ASD? كله بيحكي ASD حفظا عارفين مش فاهمين.
I swear I knew you were gonna ask this question. I knew it when I asked you.
Also, you didn't explain it in the first session?
I explained it slightly to Khalid بس ما أظن سمعت explanation but I did explain it, yes. Why does ASD have paradoxical? You know what paradoxical thrombus is? Is when you have DVTs and they go from the venous system to the atrial system through the septum. بالضبط. And therefore, when a patient with DVT comes with stroke, you immediately in the vignette think of this guy has atrial septal defect. And why wouldn't we think of ventricular septal defect? Why is it only an atrial septal defect? It's a very simple logical explanation.
There was an area.
Can the thrombus not go through the wall?
Why wouldn't we not see in VSD a paradoxical thrombus? Think of pressures.
Because it's the shift is that way.
Why? Why is that way not that way?
And both the shift is
Pressure on the left side.
Exactly.
Okay, would it go from the left side to the right? So from the right side to the left side in the ventricles?
No.
Then why did it go through the atrium? If that's the case.
Because in the atrium.
Can I say it now?
Because
أنا جاوبت أنت ما تشرح لي.
إن شاء الله.
والله I can show you.
Okay, explain.
Oh, okay, because the atria, they both have similar pressure. So it's fine if the emboli can pass from one area to the other. But in the ventricles, the left ventricle is much higher, so it's not going to be possible.
Yeah, it will never be possible because of the extremely high difference in pressure between the left and the right. But in the right to left in the atrium, there's actually just a slight difference in pressure that would allow the thrombus to jump from one side to the other side. طيب هلا طبعا واحد منكم حيكون very smart. But in the Oppenheimer syndrome the right will be higher and it will then go. By then the patient will have 10 times the problems of a paradoxical thrombus than whatever he has. يعني الإيزنهايمر syndrome هذا كثير أسوأ already. It's already bad enough. طيب okay, one more question. طيب for VSD can be membranous or muscular, which is the bigger part and which one has the bigger muscular صح؟ ممتاز. VSD and ASD is common in what syndromes? Down syndrome. Know this by heart, it's very very commonly asked about. VSD and ASD are commonly seen in Down syndrome patients. طيب tetralogy of Fallot is commonly seen in what type of patients? Tetralogy of Fallot, yes. The George syndrome. The George syndrome was known for what? Two things mainly. They don't have what? Thymus, good. Because that's why they're one of the primary immunodeficiencies diseases. What else? Thymus, and they're also known for hypocalcemia. Because they have no parathyroid glands. You're studying it from the parathyroid glands and thymus is not found in George. They're also commonly attributed to tetralogy of Fallot. Down syndrome, they're more commonly attributed to ASDs and VSDs, and it's septal defects. Last question. Actually, okay, one last thing before we talk about PDA. ASD is there's always a wide split of what? S1 or S2? S2 ليه؟
Because of the pulmonary.
بالضبط هي اللي بيصير انه what's the S2? How is the S2 sound produced?
Aortic and pulmonary valve dilation.
Exactly. شو؟
نفس
عيديها.
The closure of the pulmonary and the aortic.
Aortic. Why do we have a split? Because sometimes the aorta closes before the pulmonary. In physiological causes, this would usually be during inspiration. Why? Okay, بعدين.
So it's gonna take longer for the pulmonary one to close.
ليه؟ أول شيء, would you ever think that the right side would have more blood than the left side?
Yeah, right.
عادي.
Because the intrathoracic pressure is.
Because we just said a minute ago. We just said a minute ago.
Well, the venous return increases, but here the idea is what? The idea actually is the left side حتى it contracts before the right side because the right side is still filling up. It's not more venous return, يعني more blood in the left side than the right side than the left side. It's the right side takes more time to fill until it contracts. حتى يعني the left side بدأ the contraction, right side the center is filling شوي and then it contracts. And this is the idea بس. Specifically, but again here, okay, as you guys said exactly, when someone inspirates, it's just pressure decreases because it's increasing in size. Have more venous return. We explained this in the last lecture. How we said, imagine this was a compartment, the legs were a compartment, abdomen was a compartment, the chest was another compartment. The blood will always like to move from a lower pressure, from higher pressure to a lower pressure. But the legs would try to go to the chest if مثلا the legs were higher pressure than the chest cavity. صح ولا لا؟ ممتاز. If we inspirate, chest increases in size, lesser pressure. The higher pressure in the legs will make the blood move towards the chest. In other words, what I'm trying to say here is venous return. Increases بالضبط. Therefore, the right side will get more blood than the left side, or at least it will take more time to get more blood. It will pump slower, a bit slower than the left side. In ASD, the reason we always have a split, even in inspiration or expiration, because there's always blood flow from what side to what side?
Left to right.
Left to right. But the left is still giving the right side more blood, and the left already pumped, and the right side it's still getting blood and blood and blood, and then it pumps. هي الفكرة بس. Okay? This is why we have a split. ولا عمركم في حياتكم you'll hear it, بس memorize it for your exams. هو صراحة I heard it once in my life, بس يعني I don't know if it was a split, if it was an S3, بس كان في مرة I heard it was like dub هيك يعني, بس I don't know if it was a split or a S3. الله أعلم.
Unless we don't hear it in a normal person.
It's very hard to detect. It's easier to detect in pediatric age groups. طيب هلا with raising hands because I want to choose someone specifically. طيب حتفشل والله حفشلك.
فشلني.
Okay.
Let's go.
Patient, you do هيك ECG. شو ECG يعني؟
ECG.
You do I like to say EKG صراحة. ECG is a bad word. مش ECG sorry. لا بس هيك ultrasound in a pregnant woman. You realize that the patient will be born with a PDA. What do you give him?
Please.
انت اثنين دحيحه لا اصلا انت جاوبت كثير.
Please.
بيشنت انا سالتك السؤال ف ما اكشلي انت جاوبت. انت شو وين شو جاوب تعال.
Endomycin.
What's your answer?
Aspirin.
بصراحه it's not wrong.
It's not
ليش؟
wrong, yeah,
because it's NSAIDs. طيب you understand the idea ليش؟
Medicine is more
The same reason we give prostaglandins and transpositions of the great vessels, we give NSAIDs to stop the prostaglandins, to stop the PDA. In transpositions of the great vessels, if the patient doesn't have PDA, the right will pump to the right, the left will pump to the left, the patient is going to be born and die. Right? بدنا PDA to connect the right to the left to at least give him some time until we do the surgery to rotate both arteries. In the case of a patient just having a PDA, we want to just close off the PDA. خلاص, there's no use for the PDA. So we give NSAIDs because, as we said, prostaglandins increases شو بيفتح شو اسمه ال PDA ال ductus arteriosus. If we give an NSAID, it closes it off. ممتاز. What else do you do? For PDA. غير الانdomethacin. We don't give aspirin. Clinical trials found in endomethacin is the better medication to use. What else do we give?
For what?
For PDA. There's two things. You give endomethacin and you do something else. Kafu. Good job. Yes, because again, PDA stays due to low oxygen pressure. But we give him oxygen to increase the oxygen saturation. But it closes off the PDA. But when we close off the PDA, should be serious structure. What structure runs?
Left recurrent
Okay, left recurrent laryngeal. Where was this important in the last lecture? That's one. Aortic aneurysm. When does it happen? In what case?
Mitral stenosis.
And how do they present? With what symptoms?
Hoarse.
Yes, exactly. Did you understand this point? We're just revising what we took last time. Right? Okay, I talked about this. Okay, finally, cortication of the aorta. صح, one more thing, صح. Eisenmenger syndrome هذا ما بعرف شو اسمه again, sorry I butchered his name, but it doesn't matter. In PDA and in VSD and ASD, there is a chance where this syndrome can occur. But how would we differentiate between a VSD and ASD and a PDA?
Early or late stage?
شو يعني؟
PDA حيكون lower sinus.
مش كثير ها؟
PDA حيكون lower
ممتاز.
sinus.
This is important. Okay? Due to the syndrome HAD, in PDA when the syndrome occurs, it will only cause cyanosis in the lower limbs. The upper limbs will be fine. ليش? Because the PDA is positioned where? Exactly. After it supplies the upper limbs. In VSD and ASD, when the syndrome occurs, where would the cyanosis be? In all limbs. Because it starts from the heart. فبيكون the deoxygenated blood is starting to go to the upper limbs and then the lower limbs. In PDA, لا, the deoxygenated blood will start going through from the lower limbs, but not through the upper limbs. This is an important differentiation. بالضبط. Okay, coarctation. نفس idea of PDA تقريبا. It's present when? After. But what arteries بوكلوا هواء من الآخر? What arteries get destroyed because of the coarctation?
Intercostal veins.
Arteries. صح? Exactly.
Exactly.
طيب. So exactly the arteries, the intercostal arteries. For what do we have? What type of signs? وش اسم الساينس بالاكس-راي؟
figure of
Notching of the lips.
اسمه ساينس ما؟ أنا بعرف notching of the.
that too صح.
Okay, notching of the ribs. ما يمكن كلامك صح بس أنا know in the notching of the ribs is something that we see in coarctation of notching of the ribs because the arteries in between the intervertebral arteries have so much more blood than they're used to. طيب. So what happens is as if they're like scraping off the ribs, causing some notching in the ribs to be present. بس هي الidea بس. طيب. Like the arteries pressures are so high that it notches off the ribs. It's as if like they're breaking off the ribs. طيب. In blood pressure, what can we see that actually confirms in the divine
Hypertension upper limbs.
Hypotension lower.
Exactly. Hypertension in the lower limbs, hypertension in the upper limbs. I'm trying my best to remember a question they actually got us in the exam about this, بس أنا ناسي.
By the way, كان في شغلة coarctation of aorta with PDA and without PDA.
Infantile.
Yeah.
درستوها؟
Uh,
صراحة I remember the main topics فا explain بس أنا ما شرحت اللي مع PDA. أنا وين إن شاء الله بالهاسبيتال أبعثه؟ طب what did they talk about؟ هي صراحة we finished the lecture by the way guys. This was the last thing.
coarctation of the aorta without PDA with PDA يعني with PDA.
شو استفدنا without؟
واحدة منهم ساينوسس واحدة منهم بس hypertension. هاي hypertension with PDA حيكون ساينوسس in lower limbs مع hypertension upper limbs.
Makes sense. هي ال PDA is it exactly positioned after the coarctation?
Yeah.
Makes sense. Okay. Do you understand ليش؟
Yeah.
Why؟
لا wait بالانفانتايل بتكون before the PTA الكاركتيشن.
اوكي حلو صح. Still makes
عشان
sense.
هيك البلاد بيطلع بصير عندك سينوسس بالسيستم.
Do you understand why there's cyanosis if there's coarctation with PDA?
عشان بعد الكواركتيشن.
Look at the screen. طيب PDA is positioned, let's say here, it's after the coarctation. How does pressure move from high to low? هون the pressure in this aorta is literally zero. There's no blood. Right? But the right side, اللي هي it's coming from the pulmonary side, is higher than the aortic side. صح ولا لا؟ The blood will move from the right to the left immediately. There's no need for Eisenhower syndrome ولا هالسوالف. What happens is the right side will give the oxygenated blood, it goes to the lower limbs, causing cyanosis in the lower limbs. What presents in a similar way? PDA with Eisenhower syndrome. Fine? Did anyone not understand this point? Do I have to repeat it? We're done with the lecture. Thank you guys for attending. Sorry if I took out of time, especially the first part.